Good afternoon, everyone. So we'll start. So I'll be doing two lectures, lectures or rather discussions with you. So this is a sort of a revision session because I'm pretty sure that you all have studied and read the basic physiology of these topics. So let's move on. So I'm supposed to talk about the functions of the liver and the surgical application of those. So let's see a couple of intended learning outcomes out of this presentation. So we'll try to elaborate the main functions of the liver, and we'll try to describe the bilirubin metabolism and the clinical correlation to obstructive jaundice. To begin with, so let's look at the anatomy of the liver, which how it relates to the function of the liver. So as you know, so a liver is a structure which is about 1 to 2% of a human's body weight, and it is located in the right hypochondriac region, extending to the epigastric and sometimes to the a little bit towards the left epigastric region, hypochondriac region as well. So it is a fascinating organ when if you compare with other structures. So anatomically, it is in relation to the stomach, and the pancreas is quite adjacent to that, and you can see the spleen is also in relation, and you can see the major vessels going behind the liver, and it is wrapped by the caudate lobe behind. So basically, it has dual blood supply, which is the portal vein and the hepatic artery. So the portal vein has the majority, about 75% of the blood supply is by the portal vein, and the rest is by the hepatic artery. And you can see the hepatic artery is very small, and each and every branch that is coming up is getting bifurcated, and anatomically it is supplying the segments of the liver. So liver is made out of 8 segments, and so if you can remember, segment 1 is hiding, and segment 2, 3, I'll show in the next picture, and how the segments are divided and how it has the separate blood supply. And then the bile duct, left and right hepatic ducts are coming and connecting to make the common hepatic duct, and from which the cystic duct is originating, and it fills up the gallbladder where the bile is stored, and then it becomes the common bile duct, and it opens up at the ampulla of water at the second part of the duodenum. And so you can see the outflow from the liver is by 3 hepatic veins, and so which drains into the inferior vena cava behind the liver. So let's move on to see how this relates to the function. So there is a segmental anatomy, as you all know. Segment 1 is hiding behind, and then we have segment 2 and 3 onto the left side, and segment 4, 4A and 4B. And all these segments are receiving a separate blood supply, and the segment 5, 6, 7, 8 in a clockwise fashion is being arranged. And if you want to remember it, you can remember it with the picture of a fist of a hand, where you will see the segments, and you can see the segment 1 is hiding behind rest of the segments. So that is why the liver resections are easy, because it has separate blood supply. So you can do segmental resections during surgeries, and also it has the regenerating property, which is a benefit and sort of a unique feature in the liver, which is the only organ in our body which has the regenerating property. So moving on, so if you look at the structural unit of the liver, which is the liver lobule, so the liver lobule is made out of the branches of portal vein, and there's a branch of the hepatic artery, and it supplies blood from the periphery to the center, and it is a hexagonal structure. You can see at each corner there is a supply plus the bile duct. So the blood flows towards the center, which is the central vein in the middle, and the bile flows in the opposite direction. And so that is why, so if you appreciate this area, so the blood supply is highest at this area, which is known as the zone 1. And then zone 3 is the area where it is closer to the central vein, and zone 2 is in the middle. So these zones are identified as having separate different kind of function. In zone 1, you can see there's a lot of free or fresh blood coming up, so that there's a lot of oxygen in the zone 1. So there is a lot of oxidations happening, and a lot of metabolism taking place in the more oxygen-rich environment. Whereas as it moves on towards the center, the oxygen content is less. But most of the drug metabolism takes place in the center. So that is why in drug overdoses and toxicities, so zone 3 is working so hard to mop up all those drug overdoses, but that is the part that gets damaged very quickly because of drug overdose. So if you look at the bile duct, and so there is bile production by the hepatocytes from the other end, and there is a countercurrent kind of a flow onto the opposite side where it drains into the bile canaliculi, and ultimately it is getting collected from the bile duct and going into the common hepatic duct. So the central vein is responsible to take over the deoxygenated blood, or rather the blood containing all the products of liver is being taken out from the central vein to the inferior vena cava, and it is being distributed across the body through the right ventricle, and then so on. So if you have a more closer look at this structure, so if you see the structure of the hepatocytes and the way they have arranged. So you have the hepatic artery and the portal vein where the flow is towards the center. And then if you look at these hepatocytes, so these hepatocytes make a special area called the space of Dicey. So in the space of Dicey, there are special cells which are located, and those are known as Kupffer cells, and also there are satellite stellate cells. So all these cells are responsible for specific functions. So Kupffer cells, presence of Kupffer cells are responsible for scavenging and macrophage. It has a macrophage function against pathogenic organisms. Whereas if you look at the stellate cells, they have the storage function for fat and vitamin A, and also it can transform into cells that will convert into the cells which has regenerating properties to create hepatocytes. So that is why liver is a resectable organ which can regenerate afterwards. So these are the sinusoidal spaces, and this is the part known as the space of Dicey. So if you look at the functional unit of the liver, it is the acinus. So if you look at the acinus, so it has the terminal hepatic arterioles, and then you have the terminal portal venule also, and you have the hepatocytes, and then you have the bile ducts and the hepatocytes. So this is the kind of functional unit of the liver. If it is asked in the MCQs, you can take it as correct. And also we have the terminal bile duct which will collect all the bile and be taken out to the main hepatic duct. So there are a lot of functions of the liver. So starting from the metabolic functions, synthetic functions, secretory functions, detoxifications, and storage functions. So there's such a lot of functions that are done, and there's many more. So if you can understand these functions, then you will realize when the homeostasis is disturbed, how much the organ can get damaged. So I just want to do some MCQs with you all. So can you all try this MCQ, because it's rather a revisions session. So can you try this one and post your answer in the chat box? Yes, most of the answers are saying the correct answer is A. Yes, right. So let's see. Yes, thank you. So yes, the correct answer is A, because it has all these functions. I just wanted to kind of revise on what we discussed. Okay, right. So shall we take up next MCQ? How about this one? The liver receives approximately 50% of its blood supply from the portal vein and 50% from the hepatic artery. Yes, so the answer is B. So not from the, so 75% from the portal vein, not from the hepatic artery. So because of that, C is false, and not 25%. It is about 75 to 80%. So the answer is B. So the third MCQ, zone 1 hepatocytes are the best perfused and play a large role in oxidative metabolism such as beta oxidation and gluconeogenesis. Is it true or false? 2 says it is A, answer is true. How about the others? Right, so as I told you, zone 1, yes, it is the closest area to the portal vein and the hepatic artery, so the branches. So if you look at the acinus, so this is the area which is responsible for the oxidative metabolism and also for beta oxidation, because there's a lot of oxygen. Whereas gluconeogenesis happening. But if you look at the rest of the structures, like rest of the mechanisms, like let's say breaking down mechanism of like if you want some glucose, how do you do the breakdown of glycogen stores? So that is happening in the center part, right? So that is the different functions of the liver, and most of the detoxifications also happen in the it's not only detoxification, a lot of oxidative mechanisms are happening in the zone 1. Right, so the correct answer is A. How about this one? Zone 3 hepatocytes play a large role in detoxification and biotransformation of drugs. Yes, I got 2 answers as A. Yes, so large role in detoxification and biotransformations, which is true. So it is involved in drug metabolism in the zone 3, which is the most hypoxic area of the liver. So that is why if we go into a overdose, that area is vulnerable for injury. So the correct answer is A. Right, the fifth one. Bile and blood flow in the same direction in the liver lobule. Yes, the answer is false because it flows in the opposite direction. Right, so the answer is B. So let's look at some of the possible Viva questions on this topic. So when you study, you have to identify the scope of that particular topic or particular area of relevance. So if you look at, I mean, when I went through the Viva questions with your the registrars that I have got through, so these are the things that I could find. So they have been asking about the functions of the liver in Vivas, and also some in extent they used to ask about obstructive jaundice and how about the bilirubin metabolism. So how does it happen, and what are the crucial steps in bilirubin metabolism, and bile acids and how to synthesize bile acids and bile salts. Then about bleeding, how does bleeding get disturbed in liver disease, and neonatal jaundice and hepatorenal syndrome. So those things can be asked in surgery viva. So try to focus. So let's look at some important metabolic functions which are done by the liver. So you know how these fatty acids and glycogen are being produced in the liver. So in our diet, either we take amino acids or we may be taking carbohydrates. So when we ingest dietary proteins, or they are being digested into amino acids, so they can either enter into the pyruvate cycle or the tricarboxylic acid cycles, and they can interchange into the urea cycle. So when it goes to the urea cycle in the liver, you know, ammonia is being taken up and urea is being produced, which is excreted by the kidneys. And also, as a product of amino acid metabolism, you have pyruvates, which will be converted into glucose 6-phosphates. And so it can be given to store as glycogen in the liver. And whenever the need arises, it can undergo glycolysis, and it releases glucose 6-phosphate, and glucose is being released to the circulation. And not only that, so tricarboxylic acid cycle will produce triglycerides, which will be converted into lipoproteins, And also there's fatty acids which are being taken up from our diet and which is broken down into acetyl-CoA, and again that can contribute to the tricarboxylic acid cycles, and also it contributes in producing triglycerides, phospholipids, and cholesterol, and ultimately the cholesterol will convert into bile acids. Yes, I will share the presentation. Yes, no worries. Okay, so so that is how you can see how this metabolism happens in the liver. So there are a lot of enzymes that are involved in these metabolisms. Let's see what they are. So in ammonia homeostasis, as you know, so there is ammonia being produced during protein metabolism and as a byproduct. So there is um, uh, ammonia that is being produced in the bowel, which is circulating in the circulation. So because ammonia is lipid soluble, since it doesn't have a H plus, once it is converted with an joined with an H plus, it becomes water soluble, which is an ionized form of ammonia. And once it is water soluble, it can get excreted in the feces. But some of these ammonia ions, which are not water soluble, can get recirculated, which happens through the portal circulation. And about 85% of this ammonia is converted into urea. About 15% will go back to the systemic circulation, and so it will be circulating in the rest of the blood volume. However, this urea will enter into the systemic circulation. Since it is water soluble, it will enter into the kidneys and it will be excreted through the urine. So in addition to that, there's about 25% which goes into the bowel again, and it goes back into the urea cycle. So that is how it happens. Now you can imagine in a pathology where the patient is unable to metabolize the ammonia, there is excessive ammonia being released into the circulation. So this ammonia, since it is fat soluble, it can easily go through the blood-brain barrier. So since it goes through the blood-brain barrier, you will see the patient is getting central nervous system effects of ammonia. So that is why you will see hepatic encephalopathy in patients who has got excessive ammonia levels. So that is why we try and encourage excretion of ammonia by giving frequent laxatives, trying to keep the stools soft and clear the bowel so that the collection of ammonia is less. So that is the mechanism of a patient who is in liver failure going into hepatic encephalopathy. Right. So if you look at the synthetic functions, this is one example only, and which I pick was the most important, I would say, for your exam and then for your vivas, and even later on, you being as a surgeon, this is what is really important. So if you look at the cholesterol molecules, so you have the cholesterol molecules which ultimately results in bile salt synthesis. So usually there are two pathways. So the cholesterol can take the classic pathway or the alternative pathway. So in the classic pathway, what happens is cholesterol is uh, uh, converted into 7-alpha hydroxy. It undergoes 7-alpha hydroxylation, and that is by cytochrome P450 enzyme system. And then it undergoes 12-alpha hydroxylation. So, so because of that, ultimately you end up with folic acid and the chenodeoxyfolic acid. So, when these two acids reach the intestine, there are intestinal bacteria which converts them into 7-alpha dehydroxylation, and ultimately they end up with deoxycholic acid and lithocholic acid. So if you look at the rate limiting step here, so 7-alpha hydroxylation is one such rate limiting step. And so once this is deoxycholic acid and deoxycholic acid is produced, so you have the bile acid coenzyme A, which will conjugate um, uh, these deoxycholic acid and the lithocholic acid will be conjugated in the hepatocytes with glycine and taurine, so which will ultimately give rise to bile salts. So these rate limiting steps you need to know, because those are the places you can alter in patient management, as well as these are the steps will give rise to problems if these steps are disturbed. So once these bile salts are produced, so most of them will be excreted in the urine, or else in the feces. So that is how we get the color of urine or the feces color. So let's see what happens in the normal physiology. There is enterohepatic circulation of bile acids in normal subjects, and what happens in cholestasis. So in a normal person, the bile salts that are being produced will be excreted through the common bile duct into the duodenum, and then it will be excreted mostly through the feces, and some of them will undergo recirculation because it will be absorbed at the terminal ileum and also in the distal proximal colon, and so there is a bit of a recirculation, but you can see the most of the reabsorption happens in the distal ileum. But what happens when there's an obstruction to the excretion of these bile salts? So there is obstruction which happens in obstructive jaundice, and there is minimal excretion of bile salts through the large bowel. Instead, there is minimal reabsorption also. So you will have a lot of products that are getting extravasated, or rather going into the circulation. So that is why you will see a lot of bile acids excreted in urine, and ultimately the urine will turn into tea colored. So you will have pale stools and tea colored urine. So that is the mechanism of cholestasis, and this can be asked in viva questions in your exam. And if you have a closer look, how this happens is, so you have your bile salts, which has a hydrophobic side and a hydrophilic side. So what happens is this hydrophobic core will be catching all these lipids. Let's say the fat globules will be catched by this hydrophobic side, and then you have the hydrophilic side, so which will facilitate the absorption of fat at the distal ileum. If you look at the secretory functions, so bilirubin metabolism and excretion is very important. So if you look at your red cells, so they break down in the reticuloendothelial system, that is about 80% of them, whereas other heme proteins undergo catabolism, that is about 20%. So all these will ultimately end up in the pool of heme molecules, which undergoes the heme oxygenase enzymatic reaction, where there will be an NADPH is being utilized, and ultimately it converts into biliverdin. So when you look at biliverdin, so there is biliverdin reductase enzyme, and again it will give rise to a pool of bilirubin. So all the hemoglobin that is getting broken down, the heme molecules ultimately gives rise to bilirubin. So in hemolysis conditions, you will see a lot of bilirubin being produced, and also so if the conjugation doesn't happen very fast, you will see a lot of unconjugated bilirubin getting accumulated in the body. Right. So that is why we do the blood tests like direct and indirect bilirubin levels to see whether there is any unconjugated bilirubin, so that we know the rest of the conversion is not happening. So if you look at the mechanism of transport, so it is albumin bound bilirubins, and it will be taken up into the hepatocytes, and there's the conversion happening on, and then through the canaliculus, the conjugated bilirubin should get excreted. But there is always a reflux to plasma. So if the production is too much and the enzymes are unable to cope up all these breaking down bilirubin, then what happens is there's a reflux of molecules back to the plasma, so which will give rise to the indirect hyperbilirubinemias. So try to work out the mechanisms and the metabolism and excretion. So make your own notes and keep them ready for the exam. So if you look at the clinical picture, this is how you will see a patient who has got jaundice. So this free or the conjugated bilirubin, which is the water-soluble type, will accumulate in blood, skin, and the sclera, and also in the mucous membrane, and it will all turn yellow. So if you see a jaundice, so definitely the bilirubin level should be more than 2 milligrams per deciliter, or it should be more than 34 millimoles per liter. So there may be many causes. So it could be anything down the pathway that we discussed. It could be excessive production or reduced uptake, maybe due to reduced protein binding, or there may be reduced conjugation, and there may be disturbed secretion of conjugated bilirubin into the canaliculi. Also, it can be intra or extrahepatic bile duct obstruction, which will give rise to this free form of bilirubin. So if you look at the detoxification functions, so there are toxins, fat-soluble ones. So if you can remember, in the cytochrome P450 system, there are phase 1 and phase 2 metabolisms that are happening in the liver. So there are some of the drugs and various chemicals that are undergoing phase 1 and phase 2 reactions. So phase 1 is mostly by the cytochrome P450 enzyme system, where there is oxidation, reduction, hydrolysis, and hydration, and dehalogenations are happening. So that is for the fat-soluble toxins. And for that, we need a lot of nutrients such as vitamin B2, B3, and B6, B12. Also folic acid, glutathiones, flavonoids. So because they are needed as cofactors in these metabolizing pathways. And then if you look at the water-soluble waste material, they will undergo conjugations. So you can do sulfations, glucuronidations, glutathione conjugations, acetylations, amino acid conjugations, or methylations. So they are all being excreted via urine, bile, or stools. And so again, they also need this sort of nutrients or vitamins and microminerals for the cofactor mechanisms. So that is another function of the liver. So let's do a viva. Is there any volunteers to do a viva to answer the questions? Let's do a viva on an obstructive jaundice patient. Anyone would like to volunteer? Amila, would you like to volunteer? Amila Abevikram or Amila Disanayaka?
Yes, ma'am.
All right, so okay. So Amila, let's so you will get a question as this viva goes on. Okay, a patient presents to you with obstructive jaundice. So tell me the clinical features that you observe. What sort of clinical features will you see, Amila?
There will be icteric and darker urine and itching.
Right. Okay. So there will be jaundice, pruritus, there will be bleeding manifestations, and if you ask in the history, patient might say there is pale stools and dark urine. Right. Can you explain the pathophysiology of each of those? How does the patient get jaundice? How does he get pruritus? Why does he get bleeding manifestations?
Yeah, the obstruction, outflow obstruction of the bile
Yes.
that leads to increase the blood bilirubin levels.
Yes.
That will leads to the yellow discoloration of this sclera, mucous membranes, and other places that leads to jaundice.
Okay.
Pruritus is the local inflammation due to the bilirubin extravasation.
So irritation, actually, you can say it as an irritation.
Okay.
Yes, yeah.
Okay, and this obstruction in the backflow, the pressure leads to the changes in the liver parenchyma. That leads to the bleeding manifestation due to the clotting factor abnormalities.
Yeah. So can you think of another way that it could happen? Is there anything like any vitamins that are needed for clotting? Any idea?
Yeah, it is vitamin K.
Yeah.
Mm,
So how is vitamin K being taken up?
sorry, madam, no idea.
So how does vitamin K, is it a fat soluble vitamin, or how is it being taken up? How is it being absorbed from the intestine?
Yeah, it is fat soluble vitamin, so there's no absence of bile salt,
Mm,
and leads to reduced vitamin K levels
yes.
and
Yeah.
clotting factor difference.
Yes, very good. So you have to like see, I mean, you can use your knowledge and work out and see the fat soluble vitamins, you know the four, and vitamin K is one such, and bile salts are needed to absorb them. Otherwise, it is not happening and the cycle is breaking. And how about pale stools and dark urine? Can you work out that as well?
Increase blood bilirubin level leads the filtration through the kidney that leads to dark urine,
Mm-hmm.
and the reduced secretion into the intestine leads to pale stool.
Mm-hmm. Right. The stercobilinogen excretion is less and the urobilinogens are rising, isn't it? Right.
Yeah.
So, right. So you talked about jaundice, you talked about pruritus and bleeding, so poor fat volume, so fat soluble vitamin deficiency and with K deficiency, you said. Yes, very good. And pale stools, absence of conjugated bilirubin and dark urine because of conjugated bilirubin in urine. So can you describe the main steps in bilirubin metabolism? You like just highlight on the very basic steps. Where do you get the ingredients?
Yeah, it's heme.
Hmm.
This breakdown of the hemoglobin molecule, basically heme, then heme reduced into biliverdin by heme trit- ox- oxygenase, and
Yes.
from the biliverdin uh, converting to bilirubin by biliverdin reductase.
Mm-hmm.
Mhm.
Right.
And then
Yeah, very good. So hemoglobin gives rise to the heme and the globin. So globin gets separated, heme pool builds up and it converts into bilirubin. So yeah, it is released at the second part of the duodenum. And once there's a duodenal obstruction, maybe by a stone or malignancy, stricture, or maybe common bile duct obstruction. So then so there are many causes like for an obstruction. So it could be congenital causes, pancreatic divisions, parasites sometimes migrating, right? So, and then it disturbs the bilirubin metabolism. So you have to know the very basic steps because, I mean, this could be one stem of a uh, part of a Viva question. So you have to have a short answer as well as a long answer as needed. So what are the biochemical investigations you would request? And can you explain the basis for that?
first to diagnose the condition, whether it's obstructive jaundice, to that need bilirubin level, including total, indirect, and direct portion.
Mm-hmm.
Then you have to find the cause. What is the reason for the obstruction? For
Mm-hmm.
that, ultrasound scan
Mm-hmm.
um, to see drugs dilatations or any reason for the obstruction,
Mm-hmm.
and then to see the complication, this bleeding manifestation as the PTINR. Um,
Yes. Okay, good. Right. So that was a good flow because you look for the type of hyperbilirubinemia, that is a direct, indirect, or both, and then you look for the causes. So you are ruling out medical causes, surgical causes, and then you look for the complications. So you can, when you start your answer, you can kind of give a opening statement. I'm going to investigate this patient to look for to identify the type of obstructive jaundice, and then to look for causes and look for the complications or end organ involvements of this problem. So you can look at the serum numbers like total direct or indirect bilirubin levels, and so direct should be more than 20% of total bilirubin, then only you can say it is an obstructive jaundice. Right. So, and if the alkaline phosphatase level is very high, so it could be an obstruction to the bile duct. And so it could be a cholangiocarcinoma, or the cholangiocytes usually release the alkaline phosphatase. So if there's an obstruction, you can say it is because of a stone or maybe a malignancy even. Right. So another viva. Thank you, Amila. Is there anybody else who would like to take over about neonatal jaundice? May I find a volunteer, or is there anybody who would like to volunteer? Gihan, would you like to volunteer? Anyone else would like to volunteer? Pabasara, would you like to volunteer? It won't be difficult questions, so just, I mean, it's a time for you all to practice rather than, I mean, self-reading and learning you have to do in detail, and you need to practice. Amila, would you like to try again if others are not volunteering? Okay, that's fine, Pavasra. You are currently working, right? Okay. Anyone else would like to volunteer? Amila, would you like to volunteer again?
Okay, madam.
All right, thank you. So, what problems will neonates have when they are jaundiced? What problems will they have?
Uh, Mostly they might have the congenital problems
Mm-hmm.
in the duodenal atresia and those,
Mm-hmm.
and then this bile duct related and congenital problems like
Mm-hmm. Do you know any end organ problems when they are jaundiced? Is there any other organs, special organs that can get disturbed?
no,
Yeah, so they can go into encephalopathy and kernicterus, right? So because bilirubin is fat soluble, so it can uh, go through the blood-brain barrier and it can deposit in the brain tissues. It can cause irreversible brain damage, right? So that is the kind of major concern in neonatal jaundice, right? So what is the reason for this? Can you explain why? Why do they get bilirubin encephalopathies?
because their blood-brain barrier is not fully developed. So
Exactly.
this
Very good. Yes. So the blood-brain barrier is not, it's underdeveloped. So there are a lot of pores, not like in an adult. So these molecules can easily go through, right? And so it is vulnerable to lot of insults. So what clinical parameters to be monitored in a patient with obstructive jaundice?
their mental status.
Yes, you might be observing for fits, convulsions. You might anticipate seizures, isn't it?
It's,
Yes. Any other things?
there's a skin color,
Yes. Skin color. Yes. So,
PD.
yeah, so when they are dehydrated, how does when a newborn is born, if they are not adequately fed, or if they don't have adequate nutrient or the kind of hydration, so they become quite dehydrated, and then their kind of circulation gets disturbed, right? So when the patients are dehydrated, they can go into um, sort of dehydration as well. Right. So, hydration, how can hydration improve a patient with obstructive? Sorry, now the question is moving on to obstructive jaundice. Now we have done with the neonates. So, when there is obstructive jaundice and there's ongoing dehydration, the patient will be susceptible for hepatorenal syndrome. So, what is hepatorenal syndrome?
Uh, Acute renal failure due to the mm, failure of the liver.
Mm-hmm. Right. So when the liver fails, so there is a lot of congestion happening, and so you can imagine the portal veins and the hepatic artery. So they are struggling to go for a supply to the liver, and there is back pressure developed in the splanchnic circulation. So when there is back pressure, and the kidneys also get packed up. So ultimately, the kidney is going to failure. And so when a patient is going into a hepatorenal syndrome, so actually it is a diagnosis by exclusion. So you have to rule out all the other causes for renal failure for you to label it as a hepatorenal syndrome. And also most of the time patients will have portal hypertension when they develop hepatorenal syndrome. So those could be the reasons. And top of that, patients will be dehydrated. So they won't drink well. They won't have proper oral intake. They are so dehydrated. So all these factors will put them in at a risk of hepatorenal failure and then ultimately end up with renal failure, right? So can you tell me the rationale of management of obstructive jaundice? How can you manage? So what are the things that we need to address now?
First, we have to find the reason for the obstruction,
Okay.
and according to that, the management will vary. And then the other thing is to monitor the complications and supportive care in that regard.
Yeah.
And
Right. So
yeah.
you have to go with what is the reason for the obstructive jaundice? Was there excessive hemolysis? Whether can you stop the hemolysis? Or whether there was anything related to blood transfusions? Was there a transfusion-related reaction which is giving rise to excessive hemolysis? So likewise, you have to look for the causes. And then for the obstructive jaundice, what is the reason? Is there any other stones or anything obstructing? So you whether you have got a mechanical problem or is there a malignancy in the ampulla, whether you need a CP. Okay, so likewise you need to decide, and then you have to manage the complications. So the most unwanted complication is maybe the coagulopathy. So there you might have to tackle the coagulopathy. You might have to give vitamin K, and you might have to go up on hydration. Patient may be having a lot of dehydration, so you have to think about that. So likewise, so try to have a kind of a plan for your kind of scenarios that you might get at the exam, right? So in that context, I will stop the presentation on liver failure. Any questions that you all want to ask?
Madam, regarding liver disorders, madam, that ALT, AST level,
Yes.
how to interpret, madam, that if patient having ALT high or AST high, whether it's liver disease or as something else, how to interpret, madam, that thing?
Yeah, so ALT and AST so those are the two enzymes that are being secreted from the hepatocyte nucleus as well as the plasma. So when there is an acute liver cell injury, so you will see a sudden rise in AST. So definitely the AST will be like 2 times than the ALT. So that is a feature of acute liver injury. Whereas in chronic liver failures, you will see the opposite ratio. So you'll have a ALT rise more than the ASTs. So that you might see in the reports. But if there is massive destruction of liver tissue, let's say you have done a surgery and you have ablated the surface of the liver, there you will see lot of liver cell destruction. There's no selective nucleus or plasma destruction. There you will see both ALT, AST rise. It could happen even in trauma situations. Let's say you have got a liver lacerated patient, there you will see both ALT, AST rises. So that is how you differentiate acute from chronic liver failures, usually. Let's say you have transplanted a patient and you want to see whether the graft is working or not. So at initial stage, because of the tissue handling, the hypoxia and all that, you will have both ALT, AST rises. But with time, when the patient settles, both should come down. But in halfway through, if he gets another insult, let's say there was a hepatic artery thrombosis or a sudden ischemia, then the acute component should go up. That is AST. Right? So even when we select a donor, let's say there's a deceased donor on which we are interested and we are looking for harvesting. And then again, if the ALT-AST ratios are in opposite way, that is, if the AST is too high, we will not take that graft. So that is how you use ALT and ASTs.
Okay, madam. Thank you.
Right. How about gamma GT? Where do you use gamma GT? Ah, yes, somebody has already asked. Yeah, Sachit has already asked. So in what instance can you use gamma GT? Any idea?
It is a biliary duct system problem, madam.
Yes,
So if it is pressing together with alkaline phosphatase,
yes,
so that's a biliary duct system obstruction or any issues related to that one.
yeah. So also in alcoholic liver disease, you might see again high levels of gamma GT. It shows that there is ongoing liver damage. And that is another parameter that we monitor even in the post-transplanted patients. If there's a gamma GT high, that is a worrying feature to say that there is ongoing liver damage. Okay. How about alkaline phosphatase?
Interpreting a high alkaline phosphatase, madam, first we have to consider patient's age, madam. So those growing age patients may have a high alkaline phosphatase. That means the kids may have high levels. That is maybe normal for them. And in adults, madam, we have to check the alkaline phosphatase together with GGT and other liver enzymes like ALT, AST. If it is alkaline phosphatase increasing together with GGT, madam, it's commonly liver disease or most specifically biliary tract disease, biliary hepatic duct disease. And if alone increases, we have to look for other causes, madam, like bone marrow issue. So bone CA or ectopic pregnancies or something like that.
Yes, so it could be a bone disorder, isn't it? Yes, good. Yes, so those are the things actually. So when there is a lot of back pressure developed in the bile duct, you might see a sudden rise in alkaline phosphatase, especially with bile duct related malignancies or stones causing obstructions, where you will see rising alkaline phosphatase. Right. So how about albumin levels? How does albumin related to liver disease, and how can you interpret it?
Albumin is synthesized by liver, madam. So half-life is about 8 to 10 days. Little bit like in days, madam, half-life, days to week. So in acute liver disease, madam, that synthesis of the albumin is stopped or reduced. The patient have low albumin levels, madam.
Yes. So what are the instances, if you see a low albumin level, do you consider it as a acute liver failure patient or a chronic liver failure patient?
Maybe like chronic, madam. Acute, it takes days to weeks, madam.
Yes,
I couldn't remember exactly the dates of the half-life of albumin.
about 25 days, isn't it? Yes. So actually, if you see a drop in albumin, that is a marker of chronic liver cell disease. And if a patient should be kind of having it for a longer time for you to have low albumin levels in the plasma. Then globulin levels, how about the globulin levels?
In liver diseases, madam, globulin levels that albumin globulin levels ratio reverses, madam. That means gamma globulin is synthesized by the plasma cells, which will be remains normal, while alpha and beta will be reduced, madam. So the reversal of the globulin ratio occurs.
Yes, so you will have a reversal of the ratio, which is a feature of chronic liver cell disease, right? So in average, how is the usual kind of in a normal adult, what is the usual ratio? Let's say to albumin to total protein ratio in a healthy. So usually it is more than 1 usually, right? So either closer to 1 or more than 1 in a healthy adult. But when it goes into liver disease, so it could be less than 1, right? So the albumin globulin ratios will reduce. The other important thing is, how about the INR? So what do we do with INR?
INR is actually increases, madam, because of the clotting factors are synthesis is abnormal or stopped during the chronic liver diseases and also acute liver diseases. So INR rises, madam, and also these clotting factors have very low half-life. within days, within hours, right, madam? So
Mhm.
it will increase very quickly before that albumin levels.
Yes, so INR, let's say the INR is 2.5. A patient comes to the ward and he's a known patient with chronic liver cell disease and his INR is 2.5. So is it an indication for you to correct it?
If there's no acute bleeding, madam, and patient vital stable, no need to do the acute intervention, madam, but we can give some protein supplements and vitamin K supplements for him.
Yes, so vitamin K supplementation again, unless you have a bleeding problem or if the patient is going ahead for a surgery, you don't have to really correct it because INR is a very good indicator of chronic liver cell disease and it's a marker to say whether your patient is deteriorating or not. So because of that, we usually generally don't correct INR unless there's an indication. Maybe going for a surgery or maybe going for a some sort of a procedure, maybe a liver ablation or something like that. Otherwise, we don't correct it. We keep something ready, like let's say we keep fresh frozen plasma ready or we keep vitamin K ready, but we don't correct it because it is a marker of chronic liver cell injury. And so those are the things actually. So bilirubins, LTSTs, INR, albumin. So if you see a patient who has got albumin less than 3.5, will you start him on IV albumin to correct him? Is it an indication to start?
Low albumin, yes, madam.
Mm-hmm.
That's low.
So should you always start correct it?
I don't know, madam, the indications and all, but I guess we have to get because it's very low, madam. The patient's the general function of the physiology will be deranged severely in that case, madam. So
Yes, unless you have an indication, you don't have to correct it IV because IV correction is an acute correction and it won't last long in the body. So the long-term connection should be with nutrition. If you give IV albumin, it is just short lasting and it won't, let's say you are going to tap a patient, there, a patient with ascites, there you can give albumin to retain the colloid oncotic pressures within the vascular compartment. But giving long-term albumin will not have any help, will not do any good to the patient. Okay, it's a matter of cost only and it will not have any beneficial effect. So you have to always think why you are giving it because it will not last long in the vascular compartment. So giving albumin, thinking of supplementing is wrong. How about giving FFP? Do you all think we should routinely give FFP to liver disease patients? Do you think that it has protein in it? Anybody thinks like that? So again, FFP is fresh frozen plasma, but it doesn't contain huge protein content. It has very minute, like one in 100,000, like sort of a very small amount, and you can not compare it with the concentrated human albumin vials. But anyway, you have to keep in mind because it is plasma, you can replace the clotting factors, but not protein. Right. So because of that, I mean, giving FFP, thinking of correcting the protein is a wrong concept, right? And let's say your patient has got bit of liver failure plus little bit of heart failure also. So are you going to give him a load of FFP to correct INR? Let's say he has got upper GI bleed also, and you want to correct the INR. Now there's an indication and you want to do it. But can you just go ahead and do the FFP correction, or is there any other specific ways that you can do it in a better way?
we can do it with the furosemide cover, madam, because when we are giving albumin, that osmotic oncotic pressure increases within the plasma, so that fluid load is happens. The patient already having heart failure, so there may be worsening of the heart failure, madam.
So have
So
you heard of a clotting test called ROTEM?
yes, madam. Yeah.
Yeah, so you can do a rotational thromboelastometry, ROTEM, which is where it's like a where you take a blood sample and run this in the ROTEM machine, and it will give you a coagulation profile, right? So it gives the intem, extem, and fibtem. So intem is the intrinsic pathway, XTEM is the extrinsic pathway, and the FIBTEM. So what it does is it assesses the clot and the clot strength. And so in natural scenario, if you keep a blood sample in a tube, you know it gets clotted, isn't it? So it makes a clot, and after a while it gets lysed. So this machine is able to create a clot, and it's able to measure the clot whether it is lysing or not. So if the so this is the maximal strength of the clot. So it is shown graphically on the rotor machine, and then after a while you will see the clot lysing, so that the strength of the clot is reducing. So there are normal numbers, and depending on the clotting time, clot formation time, and so on, you can analyze whether your patient has got specific type of a clotting defect, right? So we do intend to analyze the intrinsic pathway, XTEM to analyze the extrinsic pathway, and then we do FIBTEM to analyze the fibrinogen levels. So if somebody is deficient in fibrinogen, where it is a machine where it can exclude the platelet-derived clotting, and it excludes the platelet-derived clotting, and it only extracts the fibrin-driven clot formation. And so it will show us whether we are behind fibrinogen or not. If we are behind fibrinogen, so that is an indication where you can go for cryoprecipitate. All right. So if the extrinsic and intrinsic pathways are very poor, and if the clot thickness is not enough, so that is a time where you should think about transfusing platelets. So this is a kind of a goal-directed clotting correction. So rather than going for blind techniques, nowadays ROTEM is available, and also other blood investigations like prothrombin time, right? And you can do a PT, APTT, activated partial thromboplastin time, right? So all these will direct you on which blood products and blood components to give. And also, if your patient is still not tolerating volume, there are recombinant factors. So we have concentrated 4-factor PCC, which is known as the prothrombin complex concentrates. So these are made for this sort of coagulopathic patients, where you can go for 4-factor PCC or 3-factor PCC. 4-factor means you have the 4 clotting factors concentrated in this, so then you have 3 factors, but they are very expensive. But still, it is available in the MSD and for patients if you need, right? So those are other types. So if you want to kind of risk score your patient, if you want to score your patient to say whether this patient is at a risk of liver failure, or to kind of talk about your patient, because you should have a universal language. Let's say you are talking to one of your UK friends and you want to discuss about your friends, then you should create a picture about that particular patient in your friend's mind. So how do you analyze? So do you know any scoring systems related to liver failure patients? Have you heard about the Child-Pugh score? Right? So there is Child-Pugh score for liver failure patients, and then you have UKELD score, UKELD, that is end-stage liver disease. So these are the scoring systems. So if you use your phone and the Medcal, so these are available as apps where you can use, and also the MELD score. Either you can calculate them manually, so which will show the risk of a patient dying, or the mortality of a patient without a liver transplant. So these scorings will give you how long can they live without a transplant. So there are certain criteria which they take into consideration, like the bilirubin level, serum albumin levels, the encephalopathy status, ascites, free fluid, right? And the INR level. So likewise, they take 5 criteria, and based on that, they grade the patient. So Child-Pugh can be A, B, or C. C is kind of a very bad situation, and A is a controlled patient. So UKELD, if the UKELD criteria is more than 49, we list them for liver transplant. So likewise, so there are criteria that we take up to say whether these patients are, how long can they live without transplant. So that is how you analyze liver failure patients, right? So these are the scoring systems that are available for that. So any other questions? The last part of the question, post-hepatic, which question? May I know which question you want to summarize? Post-hepatic. I'm not very clear about the question. So which question? ALT-ASTs. All right. Okay. So ALT-AST. So if you look at AST is the and the INR. All right. Okay. Got it. So to tell again, so AST is the enzyme that you will see in acute liver failures. You will see a rise in AST. Whereas if you have got a patient with chronic liver cell disease, you will have usually the ALT is slightly higher than the AST. So if you have a acute insult, you call it as an inverse ratio, where you see the AST is going up than the ALTs. So if you have got acute insult to the liver, let's say you have got a trauma, or you have got a ablated liver, or you have got a resected liver with lot of raw surface area being coagulated, then you will have both ALT, AST rising in your reports, right? And so NAC, N-acetylcysteine is another thing. I mean, there's no proven benefit, but it is being used during liver failures, and also it is in the King's College criteria also. In paracetamol overdose resulting in acute liver failure, they recommend. So this ALT-AST will be your guide to identify whether the patient is in has got an acute insult or whether this is a chronic insult. So then looking at INR so it is a long-term indicator of the liver disease status. So when a patient is having chronic liver cell disease, usually the INRs are, the normal INRs are in a higher level. But unless they get any kind of an insult, they don't bleed. But if they happen to bleed, then you need to correct. Otherwise, if there's no ongoing bleeding, you don't have to correct the INR. So that is what I told about the INR. Right. Okay. And the albumin globulin ratio, yes. So usually it is less than 1 in healthy adults, but in liver disease, your albumin is going low, and so it turns inverse, right? So usually it is more than 1, and it inverse when the patient is getting going into liver disease. And again, albumin level is a long-term indicator of liver failure. So giving acutely correcting albumin will not have any benefit. So you have to correct it with nutrition. But if you have some sort of acute correction that you need to take up, like to increase the plasma colloid oncotic pressures, there you can use the albumin. So any other questions? We can move on to the cardiac lecture if you all don't have any other questions. Right. Okay then. So these were a few references that I went through. So Canon, as you all always read, and a special book for liver disease. So and many other, and there was another nice article also in CBI. So I mean, there are a lot of reading material. Read through and make your own notes and study. And so I'll wind up this session, and I'll join you all with the cardiac output monitoring. Thank you very much. So for your listening.